So where did this all begin? Medical sex change interventions are often advertised as the latest best practice, developed in response to a better scientific understanding of gender identity. In fact, they are neither new nor particularly scientific. The first sex change surgeries were performed over a century ago in Magnus Hirchfeld's Sex Research Institute in Berlin. Hirchfeld believed that there was a biological driver of what he called extreme transvestism, and that his distraught patients would harm themselves if he and his surgeons didn't facilitate their castration desires. The case of Elna Wegener, or Lily Elbe, glorified recently in the movie The Danish Girl, was one of the first highly publicized case studies of the treatment methods developed in Hirchfeld's clinic. Wegener died from surgical complications. Hirchfeld's theories and methods were introduced to post-war America by Harry Benjamin, who admired Hirchfeld's work. When hormones first became available in the 1940s, Benjamin began experimenting with these on male transsexual patients to help feminize their appearance. His most famous patient was George, or Christine, Jorgensen, whose 1952 sex reassignment surgery in Denmark was the first to be widely reported in the press. Benjamin's methods were always controversial. Mental health professionals felt that the less drastic approach of attempting to have the mind accept the body was preferable to sex change. But Benjamin disagreed. He regarded the risk of suicide or self-mutilation as significant in the absence of sex reassignment. The Benjamin method began to attract mainstream interest with the opening of a gender clinic at Johns Hopkins University Hospital in Baltimore in 1966. One of the clinicians working in this area was New Zealand psychologist John Money, whose work in adapting sex change protocols to treat children is now synonymous with surgical abuse. An independent review of this clinic in 1979 found no benefit, and the practice was closed down. At that point, clinicians who still believed in the benefits of sex change formed their own society, the Harry Benjamin International Gender Dysphoria Association. In 2007, this organization changed its name to the Worldwide Professional Association for Transgender Health, or WPATH. WPATH's standards of care, and later those published by the US Endocrine Society, came to be regarded as the standard guide to practice because no other medical associations were advocating for this treatment model. A similar organisation, now known as OzPath, started in Australia from around 2001. At first, the clinicians working in this area of medicine confined themselves to the treatment of adult patients. Some of them worked collaboratively with these patients to better understand their problems and to advocate new standards of care and to lobby for better access to treatments that were otherwise restricted. Some people regard this collaboration with the community as a great strength of gender-affirming medicine, but others began to be concerned that activism, rather than science, was guiding the recommendations of these professional networks. In 1998, the US psychologist Dr. Stephen B. Levine chaired the committee that wrote the 5th edition of WPATH Standards of Care. But by 2002, he resigned his membership, having with regret come to the conclusion that the organisation and its recommendations had become dominated by politics and ideology rather than by scientific process. In 2011, WPATH launched the 7th edition of its Standards of Care, which enshrined a new approach to gender medicine, the informed consent model, also known as gender-affirming care. Where previous approaches had diagnosed gender identity disorder as a disorder and sex change as the treatment, the informed consent model begins with the premise that gender incongruence is not a disorder. The purpose of treatment is not to help the patients reconcile their self-concept with their biological sex, but rather to alleviate the distress that arises from gender incongruence by helping affirm and express their gender identity, including through medical sex trait modification. The role of the doctor, once they've explained the risks and benefits of treatment and the patient has signed a document demonstrating their consent, is simply to facilitate the patient's goals. Doctors who adopt a more cautious approach are criticised as gatekeepers for creating unjustified barriers to medical gender affirmation. From 2013, the American Psychiatric Association changed its previous diagnosis of gender identity disorder to gender dysphoria, which had the effect of redirecting treatment objectives. Instead of treating gender incongruence itself, clinicians were treating only the distress that might arise as a consequence of gender incongruence. It was around this time, in 2011 to 2013, that the numbers of children presenting to gender clinics all over the Western world, including Australia, began to rise. As mentioned in previous episodes, Mia Hughes and the Environmental Progress, who exposed the WPATH files, revealed conversations between surgeons, clinicians, and activists regarding transgender treatments and surgeries, showing that, amongst other things, many professionals affiliated with this group are aware of the harmful effects of cross-sex hormones and surgery. WPATH was explicitly criticised in the Cass Review for its lack of developmental rigour. So let me retrace. Inspired by Hirchfeld's sex change work in Berlin, Henry Benjamin began to experiment with hormones in post-war America, which, even though it was controversial, was developed into actual practice in the Johns Hopkins Gender Identity Clinic, where John Money applied the principles to children for the first time. After little more than a decade, the clinic was shut down, and the claimed benefits of sex change were widely discredited. Despite this, those who believed in it formed the Harry Benjamin International Gender Dysphoria Association, which later became the Worldwide Professional Association of Transgender Health. The WPATH files confirm that clinicians associated with this organization are ignoring the known serious harms associated with medical sex trait modification procedures. The model of care pioneered by WPATH, which has given rise to a significant expansion of a formerly niche field of medicine, is now found by the Cass Review to lack developmental rigour and rests on shaky foundations. The WPATH files argue that WPATH's approach to medicine is consumer-driven and pseudoscientific, that its members appear to be engaged in political activism and not science, and that sex trait modification procedures on minors and people with mental health disorders, known as gender-affirming care, are unethical medical experiments, causing harm without justification, and that its victims are some of society's most vulnerable people. Arguably, transsexual and transgender medicine has been flawed from the start. The theory of identity that underpins these interventions keeps shifting, and the suicide narrative that proponents use to justify it has been debunked. It's time for all Australian parliaments to conduct a thorough inquiry into gender affirmation for children in Australia. It's time we had our own version of the Cass Review.